again, you just tell the patient, I'm just going to push you back here just a little bit so you're not so close to the edge. Just like that. So have the patient look as though they're in a little bit of lordosis. If a patient has a very, very wide pelvis and a very narrow waist, some clinicians like to put just a little bit of towel or perhaps a pillowcase to fill this area in here so the patient's not side bent. Again, that's optional based upon the construction of the patient's pelvis. You do not need a towel in for everyone. But if again the pelvis is wider and the waist is narrow, and you see that they're side bent toward the table, I would put a little bit of something in here. Next most, and probably a little bit more important than that, is that you palpate the multifidus, and that you make sure that on each side it's relaxed, and that the patient's not guarding. Because if either side, the right or the left, multifidus muscle is not relaxed, you won't feel too much joint. If one muscle is guarding, you feel it tense. Sometimes if you just play a little bit with the leg position or the body position, okay, you can get them to relax. So you just move the patient just a little bit, and then if both muscles feel soft, they're not contracting, you should be all set to go. The femurs are going to be at about a 60-degree angle to the trunk. Okay. In our first test, we come with our caudal thigh, and we're going to push in a dorsal direction through both tibia. So you're right about at the level of the tibial tuberosity. So I'll push dorsally, and then with my left hand in this case, pull ventrally, just a little bit. And I try to get as even a push and a pull through both femurs as possible. And the push-pull is very, very short. You almost want to think of it as a little jiggle. So I guess that's what I'd like you to note the most right now, how short I'm keeping this. You could choose to start up at L1 and work your way down. Or you could start at L5S1 and work your way up. And you're looking for, if we're talking about hypermobility right now, let's reference that first. You're looking for a very distinct change in the amount of segmental translation. Meaning, for example, if you started at L1 and we're working your way down to L5, you should probably feel a little bit more segmental translation at the L4 segment and the L5 segment, because both of those segments are supposed to have more angular movement in the sagittal plane. They flex and extend more than L1, 2, and 3. So it's probably normal to feel a little bit more joint play at the two lowest lumbar segments. What's not normal, though, is to feel hardly any joint play, just a very little, and then all of a sudden you feel big movement. It moves very easily. Okay? So there's sort of a real distinctive change in the segmental motion. If it's a slight change, that's okay. If we now reference hypomobility, spine that's stiff, tight, okay, as opposed to feeling a small bit of motion at each segment, okay, the segment moves a little bit more like this. Okay. The whole thing sort of moves back and forth, almost like a block. So again, the first technique, I'll come up to L1 now. Nice and short. All the way down to the L5S1 segment. So that's one way to